أنا النهاردة هنا في روما بناء على دعوة كريمة من أستاذي الأستاذ الدكتور انريكو فينازي أجرو، أستاذ ورئيس اسم المسالك البولية في جامعة فيرجاتا في روما. وكنت اتعرفت عليه في شهر 9 اللي فات في مؤتمر التهاب الجمعية الأوروبية لالتهاب الاعصاب السكري، وكان الراجل بيشرح لنا الطرق الجديدة في علاج التهاب الاعصاب السكري اللي بيصيب المثانة وبيخلي الناس ما تتحكمش في البول، فبيعمل سلاسل بولي او عدم القدره على التحكم في البول. ده بيبقى اكتر في الستات عن الرجاله.
يسعدني ويشرفني اني اكون بكلمكم النهارده من روما، من مستشفى جامعة فيرجاتا في روما، وجيت هنا بناء على دعوة كريمة من أستاذي وصديقي الأستاذ الدكتور انريكو فينازي أجرو، أستاذ ورئيس اسم المسالك في مستشفى جامعة فيرجاتا، وهو في نفس الوقت سكرتير الجمعية العالمية والجمعية الأوروبية للسلس البولي. Good morning, Professor. Would you please, sir, introduce yourself?
Yes, thank you. I am Enrico Finazzi Agro. I am Professor of Urology at the University of Rome, Tor Vergata, and I am the chair of the Urology Unit of the Policlinico Tor Vergata University Hospital in Rome.
Okay. What will you talk to us about today, sir?
I think we are going to talk about incontinence and generally lower urinary tract symptoms, especially in diabetic patients, but we will see. I mean, we will discuss about functional urology in general, I think.
I have come to Rome by your wonderful invitation, your very generous invitation, to learn about incontinence and how to manage it. How does incontinence come into diabetes? What's the relationship?
Yes, we know that diabetes can provoke peripheric neuropathy.
Yes.
And this neuropathy can have, let's say, different stages along the life of the patients. Usually in the first part, in the first years, it may produce, let's say, an overactivity of the bladder. So the bladder becomes less able to hold urine. The capacity can lower, and so the patients have to rush to the toilet. They have to go urgently to the toilet. So we call this overactive bladder, and this is a very bothering condition for our patients, of course. Then during the course of the life of these patients, the neuropathy advances, goes on, and so usually the second part is a situation that is completely the opposite. So the bladder becomes less sensitive, the sensation goes down, so the patients may not feel the desire to void, the bladder becomes
Bigger?
Exactly, and it's very difficult to void the urine, not to hold the urine. So the retention, the first part is more related to incontinence, the second part is more related to retention. And of course, it's very important to try to identify these two different situations in different patients to prevent the complications. Plus, I would like to add that the male patients may also have problems with their prostate. So you know that almost all patients above 50 have before or after what we call benign prostatic hyperplasia, so the increase of volume of the prostate, and so the prostate is obstructing the flow of the urine, and so this will deteriorate even more the situation.
Yes, this is wonderful. So we can say that people with general population first, can someone who doesn't have diabetes have this problem?
Yes, also those people who have not diabetes may have problems for two reasons. Male patients have the benign prostatic hyperplasia, but all patients are aging, and aging also is a risk factor for lower urinary tract symptoms. Usually aging is related with the overactivity of the bladder, so I see a lot of patients who come to my attention because they have to rush to the toilet, they have to go urgently, or they have to wake up at night 2 or more times, or they have to go very frequently during the day to the toilet. This is very much related to aging, apart from diabetes.
Wonderful. Okay, so my next question here will be, what about how common it is?
It is in diabetics patients?
Both in diabetics and in non-diabetics.
Well, lower urinary tract symptoms are very, very common in the general population. You can imagine that a study in Europe showed that around 17% of the population may have OAB, overactive bladder, that means urgency and increased frequency to go to the toilet. Lower urinary tract symptoms in male patients above 50 are a condition that account between, let's say, 50 to 80% of patients with increasing age. So it is very, very common. In the diabetic population, this is even higher. So of course, if you exclude the very young patients with diabetes, but that
let's
may
say
also
above 40.
Above 40, it's very common, even more common than in the general population.
Okay, so this is the problem. Okay, the types are first there's stress incontinence. Whenever the woman coughs or strains or does anything, a bit of urine falls down. Then there is urge where they have to go to the toilet right now.
Yeah, exactly.
Okay. Then we have the neurogenic bladder where they have the urine, they can't void it, it stays inside and they don't feel it. Okay, and this is the worst type because it can affect the kidneys. Okay, and we know that it is quite common both in the general population, especially with age, in men and women. Which is commoner, men or women?
Incontinence is generally more common in women. As you correctly stated, we have two kinds of incontinence. Stress incontinence and urgency incontinence. Stress incontinence is only for women, I would say. Stress incontinence in men is possible only after surgery for, let's say, for prostate cancer, or maybe in neurogenic patients.
So in massive surgeries, after massive surgeries?
After massive surgery, exactly, or pelvic surgery specifically.
Okay.
Urgency incontinence is possible in both sexes, and it's more related to age, as I said before. But in general, incontinence is more common in female patients.
Okay. My last question here would be about, so this is the problem. How to solve it?
So we have different solutions. Let's start with the so-called behavioral and rehabilitation treatment. And behavioral treatments mean that you can use some kind of changing of or your habits to improve the situation. For instance, many people drink too much, and you can reduce the amount of
drinking, like alcohol, not water.
No, also water. I mean, I was meaning water. Okay. Of course, alcohol may deteriorate the situation, so you have to reduce at least the amount of alcohol that you have during the day. But I was talking about water. I mean, people can drink 4 liters of water. It's absolutely too much, and they have to reduce this amount. Another kind of behavioral treatment is the so-called timed voiding. So people have to go at certain time to void, even if they don't feel the urge to urinate. And for instance, this is a situation that may be useful in some diabetic patients because they don't feel the urge to go to the toilet. Another kind of behavioral treatment is the so-called bladder training, that is a little bit the opposite. So they have to try to hold urine, they have to stand up, walk, or doing other activities that can mask a little bit the urge to go to the toilet, and they have to gain a few minutes every time, and at the end the bladder can regain some capacity. This is the behavioral therapy. There are rehabilitation treatment that is usually based on the exercise of the pelvic floor muscles. This is more useful for stress urinary incontinence, but can be useful also for urgency incontinence. And then there is usually a pharmacological drug therapy that is based on antimuscarinic drugs or beta-3 agonist drugs. In this moment we have several antimuscarinic available on the market, at least in Europe, and we have only one beta-3 agonist, but another one is coming. We have mirabegron up to now, and vibegron is coming. It's already available in some countries.
It's the same state in my country. It's the same state in Egypt.
Okay.
Same drugs.
And so we have these different drugs. Antimuscarinic drugs are very effective, but they come with a lot of side effects, comprising the possibility of some central side effects like dementia in the long term. And on the other hand, beta-3 agonists have much less side effects, but mirabegron is related with the possibility to increase the blood pressure, so it must be
heart rate.
Exactly, it must be used with care in some patients. Vibegron seems more safe, and so
let's hope so.
So exactly, we have still no direct experience on that, but it is available in the US, for instance, has been available since at least 2 years. So I think that the results are good. We will see in the next future in Europe also this drug. After these, let's say, first-line treatments that are, let's say, non-invasive, we have some more invasive treatments. Among those treatments, I think that the tibial nerve stimulation is the less invasive one because it's an office-based treatment. You have to punch a point a little bit above the ankle of the patient to stimulate the tibial nerve.
So basically, you put a needle inside the tibial nerve inside the leg. Okay.
Exactly. You stimulate with fixed parameters electricity. Okay. So you increase until you see the big two flexing, or until the patient feels some prickling on the foot, or sometimes the other fingers of the foot can move. And you know that you are stimulating the right point. The stimulation lasts for 30 minutes. Usually it's done once a week. And the course is long. It's like 10 or 12 sessions. So if it is done for once a week, it's 10 or 12 weeks. You can do that twice a week or 3 times a week to, let's say, to have the results before, to anticipate the results. And this is probably the most, the easiest thing that you can do. After that,
how effective is this treatment?
It is in our hands. It depends on the selection of the patients.
Okay.
In our experience, this is something that it can be effective in around, let's say, 60 or 70% of patients, and you have to consider that these are already difficult patients because they already didn't respond to the pharmacological and behavioral treatments. So 60-70% is effective, especially for overactive bladder. We use this also for underactive bladder. This is strange, but this is strange because something that is effective on incontinence is strange that is also effective on retention. But probably we have understood with time that there is a sort of balance in our brain between feeling of fullness of the bladder and no feeling, no sensation of fullness. So if there is an imbalance, no feeling, you go to retention. You have too much sensation, you go to incontinence, let's say, to make it simple. So this kind of stimulation that is called neuromodulation tries to restore this balance, and so it's good for OAB. For OAB, this is a standard technique, but maybe used also for retention.
Okay. So after we do this and it fails, what to do next?
After we have still
first, before we go to the next possibility, we do first the 12 sessions, and then we need maintenance.
Yes, usually this is not something that solves the problems. It fixes the problem for a limited amount of time. Then, if you don't go on with the stimulations, you may lose the results. So there is a need of a chronic stimulation. You can use a home treatment. There are some devices that the patient can buy and use at home.
Or can
for instance,
come to clinic.
or can come to clinic. Or
How
can come
frequent?
It's very variable from patient to patient. Let's say once a week to once after every 2 weeks, something like that. They should go on. Maybe you can extend this time up to once per month. But this is very variable from patient to patient. Okay, but there is a need of a chronic stimulation.
Okay.
This may be also a good aspect in a way, because you have the possibility to check the situation of your patients. Probably also patients may be more, let's say, confident because they see you more regularly, and so in a way it's good for the follow-up of the patients. But this is, let's say, something that you have to know, because if you treat the patient with PTNS, PTNS is the acronym for percutaneous tibial nerve stimulation. Exactly.
Yes.
You treat with this technique. Then if you abandon your patient, the results will go out.
Will fade out with time.
Exactly. Will be
Okay.
lost.
So we did the PTNS. It worked or it didn't. In this case,
if it doesn't work for overactive bladder, there are other two options.
Yes.
One is sacral nerve neuromodulation. In this case, the concept is the same. You stimulate a nerve, but with an implant. So
in the spinal cord.
Not in the spinal cord, but on the sacral, the third sacral nerve. So not exactly in the cord, but on the nerve. It's on the back,
yes.
On the
Okay.
sacrum, the sacrum. In this sense, yes. And you put a small, let's say, needle, a small electrode there, and the stimulator is like a pacemaker, go under the skin in the gluteal part of the patient, and the patient lives with this stimulator, like a pacemaker for the heart.
Yes.
And it's something more strong, let's say, than tibial nerve stimulation, but also more invasive, let's say. So usually we do this when tibial nerve stimulation fails. The other possibility is botulinum toxin.
Yes.
Botulinum toxin is a drug that can be injected in the bladder wall, and it blocks the overactivity of the.
So you go in with an endoscope into the
you
bladder?
You do a cystoscopy, exactly. Usually a flexible cystoscopy. We do that in our offices. It's not something that you have to do in the operator. You saw it. You can do that without having the patients under general anesthesia in the theater, in the operatory theater. It can be done in the office. It's very easy. Usually it should be also, this is not forever as well. Usually it must be repeated every 6 or 12 months, let's say between 6 and 12 months. So the patients should be aware that the treatment should be repeated. And basically for lifelong, but sometimes the blood can be re-educated, and so in this way you can stop the treatments.
Yes. By the way, we didn't mention other conditions other than diabetes which may have benefit from this treatment, like told me multiple sclerosis.
Yes, some kind of neurogenic neurological pathologies causing neurogenic lower urinary tract dysfunctions can be a good indication for using PTNS or even sacral nerve neuromodulation. I think that multiple sclerosis patients also, this you saw it yesterday. Yes. These patients may be very prone to respond to this treatment, and it's very good because electric stimulation is not something that improve continence, but deteriorating the voiding phase, because some drugs like antimuscarinic drugs can exactly improve continence, but may cause retention or at least deteriorate the voiding efficacy of the bladder. So with the electrical stimulation, this is not a risk. So improve both sides
Also, I saw yesterday patients with Parkinson's.
Also, Parkinson can be an indication for that. I mean, all the different neurogenic condition may be an indication, but of course there are some limitations. If you have, for instance, a spinal cord injury with a complete lesion, probably there is no indication for that because there is no connection between the spinal cord and the blood and the brain, and so the efficacy of the treatment is not that good, unfortunately.
Yes, this I really can't thank you enough. First, for inviting me here. Second, for teaching me. And third, for letting me in your clinic to see it in action and to learn how it is actually done. I really can't thank you enough. I am very happy to have met you. I am very happy with all which I have learned from you. And thank you so much. Thank you, Professor.
It was a pleasure to have you with us. And let me say that it's also important to have this collaboration between different specialties, because I am a urologist, you are an endocrinologist. I think it's very good to talk each other and to learn from each other. So I think this is very good. And if I can say something to the people who are listening.
Yes, the people of Egypt, yes.
Yes, I think that, for instance, the International Continence Society is a society that is not for urologists, it's not for gynecologists, but it's for all people who are interested in incontinence. So if endocrinologists are
currently, I'm very interested.
Are very interested in incontinence, they can come to this society. This year we will be in Abu Dhabi. So it's
really?
In September. So if all of you want to come from Egypt to Abu Dhabi, you will be very welcome to participate to the meeting of the International Continence Society.
Okay, I hope I'll manage to do it and it doesn't clash with the EASD or our conferences or the Neurodab or something. Okay. Anyway, I thank you so much.